much. Dr. Maxey.
Thank you. Good morning. Thank you for your time, Chairman Casey, Senator Braun, distinguished members of the committee. Time waits for no man. The issues of the aging are the issues of us all. I applaud the committee's commitment to supporting the communities of care for our honored aging citizens. As Ranking Member Braun mentioned, my experience as a healthcare professional and a workforce researcher are broad and have extended more than 2 decades. I am here today as a health workforce policy expert to speak to the solutions that states are developing and implementing to build and strengthen their home and community-based services workforce, or HCBS workforce. I'm delighted to be joined by my son, Sebastian, who's currently working on his Eagle Scout project back in Fishers, Indiana, and is deeply interested in American government. In the balance of power between the federal and state governments, states oversee policy and programming related to workforce development, occupational regulation and public protection, and social services. All of these have a direct impact on the HCBS workforce. Keeping a finger on the pulse of related state efforts is critical to understand the national landscape and ensure policy alignment from the halls of Congress to our state general assemblies and ultimately within the homes of our seniors. I'm delighted to have provided research support to my home state on the Indiana Direct Service Workforce Plan. This initiative is a foundational part of LTSS reform in Indiana, seeking to enhance access to HCBS services. Indiana is one of numerous states that have engaged in planning to develop and strengthen this workforce. Many of the strategies I will discuss today are a part of Indiana's plan. Also, I would like to note that although these strategies may be beneficial for the private sector, my research and expertise on these matters is focused on state solutions. HCBS quality metrics recently released by CMS are appropriately focused on member experience. What is not in writing is that achieving many of these metrics hinges upon the availability and dependability of a competently trained workforce. HCBS workers require certain skills to care for our honored aging, regardless of whether that worker is employed by a provider or a self-directed consumer. Training standards support a minimum level of quality. Some states have developed portable credentials for individuals that have met training standards. Frequently, these are implemented through registries for qualified workers. Portable credentials empower workers by demonstrating their training achievements and facilitating their pursuit of economic opportunity among new employers, in new settings, or through additional academic training and stackable credentials. Empowered workers power our economy. Training registries can also empower employers and self-directed consumers by enabling them to verify that a worker has achieved training standards prior to entering into arrangements. When coupled with incident reporting and high-fidelity investigation processes, state registries can also protect the public from bad actors. Self-directed consumers and employers alike can query these registries to ensure that a worker does not have any substantiated abuse, neglect, or exploitation claims against them. In addition to consumer protection, registries offer states an opportunity to collect supplemental information on their workforce. Such information is useful for workforce assessments, targeting development initiatives, and evaluating the impact of these initiatives. Indiana is a leading state in this space, recently having leveraged such information to identify and strengthen career pathways for the facility-based direct care workforce. Wage is commonly cited as the greatest challenge to the HCBS workforce recruitment and retention. State Medicaid programs are the single largest payer for LTSS services in the United States, but the true cost associated with our public LTS services are even greater when we account for the many HCBS workers who qualify for and receive public assistance such as Medicaid, SNAP, or TANF based on their income. Recognizing Medicaid's influence over HCBS workforce markets and wages, many states, including Indiana, have developed targeted initiatives to enhance wages and benefits. Such strategies include competitive rate setting, wage pass-throughs, and value-based incentives. A conundrum within these discussions is the impact that wage enhancements can have on worker benefits. As I just mentioned, many HCBS workers receive public assistance. Strategies which increase wages to just over public assistance qualification can negatively impact overall income. This is commonly referred to as the benefits cliff. States are exploring where these cliffs exist to ensure their solutions are data-driven and have a net positive impact. I'd like to thank you for this opportunity to brief you on the great work going on in Indiana and states across our nation to uplift older Americans and the workforce that is supporting them. Thank you also for your leadership on this topic and your commitment to supporting and advancing state solutions.
Dr. Maxey, thanks for your testimony. Ms. Lowe.